Hi. Hi, Professor Muharrem.
Hi, Muharrem. How are you? Uh,
Yes. Can you hear
Yes.
me now?
Yes, yes. Welcome. How are you?
Good. How about you?
The Max IB has just connected. Uh, I think Max, can you unmute yourself?
No, can you hear me?
Welcome. How are you?
I'm okay, thank you.
Good to see you. We have done a mistake that in some announcements it is at 5 p.m. with Turkish time. In others it is 6 p.m. So please apologize for us. And then I think since we have gathered many people already, we can start the first speaker and you can make the moderation, Max.
Okay. So, do I see the speakers? So, yeah. Yes.
The first speaker is with us, Dr. Yahya Güvenç.
Yes.
Muharrem is also here. The others will come by the time, I think.
Okay. Okay. So, welcome, Dr. Yaya.
Thank you, Professor Abi.
And I think you're going to talk about the classification and the clinical appearance of congenital scoliosis. I think this is a very complex issue, and there is always debates about classification. So we're looking forward to hear what you have to tell us. So please go ahead.
Thank you. Thank you. Welcome again. I will try to explain a classification and some of clinics. We don't talk in this presentations treatment methods and surgery. The other speakers continue with surgery. I'm apologize for I'm in airport. We are going to do WFNS education course. Because of that, some voice maybe come outside. I'm sorry again. Now I will start. The scoliosis, when we look at the scoliosis, this is early onset scoliosis, adolescent idiopathic scoliosis, and adult degenerative scoliosis. We talk about the congenital scoliosis. We focus on that. And congenital scoliosis, it is a spinal deformity, occurs due to failure of normal vertebral developments during the 4th and 6th week of gestations. And sometimes assess for neural axis abnormalities, and prevalence is high between 1% and 4%. And when we look at the congenital scoliosis etiologies, there are genetic defects. There is some carbon monoxide exposure during the formation period, sometimes fetal hypoxia, sometimes gestational diabetes, and antiepileptic effect again, and prolonged febrile starts. And there are some associated anomalies: neurological malformation, congenital heart malformations, urological anomalies. Most of them is neurological malformations, and 35% of these patients has diastole or Chiari malformation or intradural lipoma or tether cords. And sometimes associated anomalies is congenital heart malformations. We can see 25% of the patients, pallotetralogy, transposition of the great vessels, and sometimes urological anomalies, 20% of the cases, horseshoe kidney, vesicoretral reflux, hypospadias, and inguinal hernia. And when look at the congenital scoliosis etiologies again and pathologies, some of the pathologies occur from the osteopathic vertebra, some of the occurs from neuropathic pathologies. Osteopathic vertebral and skeletal anomaly, failure of formations, failure of segmentation, and mix. We will talk again for this. And neuropathics are spinal bifida, tethered cord syndrome, myelomeningocele, syringomyelia, and Chiari-1 malformations. And this is the terminology. Formation failure, we can fully segment it. This is the hemivertebra, fully segmented. We mean we can disc adjacent levels at superior and inferior. This is fully segmented. And this is semi-segmented hemivertebra. There is a dissipate, but there is a fusion area. This is semi-segmented, formation failure. And non-segmented, this is non-segmented. There is a fusion in upper level and below levels. And there is a segmentation failures. For example, this is unilateral non-segmented bar this is. And this is block vertebra. Block vertebra, all of the vertebra is, there is a fusion, sometimes 2 or sometimes 3, sometimes more than 3. This is the terminology, and we will use in this presentation and other presentation. When we look at the classifications, there's a winter classification. All of us know this classification because most used classification is that winter classifications. It's written in 1966, and there is a failure of formations, and the second is failure of segmentations and mix. Failure of formation, we can see again, this is the wedge vertebra, this is hemivertebra full segmented, this is partly unsegmented vertebra and unsegmented vertebra. This is formation failures and segmentations failures. This is block vertebra, and there is a bar, and there is a bar and contralateral vertebra. But in during the time, we started to use 3D CT images, so we can see other anomalies at the anterior of the spine, sometimes only posterior of the spine. And sometimes we find new mixed vertebral anomalies. So we outstand it to winter classifications, because winter classifications depend on use of plain X-ray images, and all formations failures don't encompass it in these winter classifications. And mixed category is when we use to CT 3D, we see a lot of mixed. So Imagine and et al. Classifications, they write new classifications, and they look at the anterior component of the spine, and they look at the posterior component of the spine. In anterior component, there is a hemivertebra, hemipedicle or butterfly vertebra, lateral wedge vertebra. Posterior component is fully segmented hemilamina, semi-segmented hemilamina, and in winter classification we can see that and spina bifida, bilamina compliant or incompliant, wedge lamina, and accompanied with spina bifida. And Kawamarki classification again depends on 3D CT studies, and they write this paper in 29, and they divided congenital scoliosis 4 types. Type 1, solitary simple congenital malformation. We use this type 1 frequently in congenital scoliosis. For example, sometimes hemivertebra, sometimes wedge vertebra, sometimes butterfly vertebra. In type 2, multiple simple anomalies, combination of hemivertebra, wedge vertebra, and butterfly vertebra. Discrete, adjacent, or odors. And type 3, complex anomalies, mixed, and type 4, segmentation failure only segmentation failures. And then in 2015, some of the authors again make another classification, Bornei-Gavrilli classifications. And these classifications depends on coronal and transverse view of the spine, because they look at the longitudinal view of the spine and they find again in 3D images rotational imbalance. All the classifications didn't look at the rotational imbalance. This is differences between Bornei-Gavrilli classifications. And they divide to 2 main categories. One of them is longitudinal congenital scoliosis with longitudinal imbalance. For example, we discuss this in other classification again. 1, formation failure with or without fusion failure of the ossification centers. A wedged vertebra, this is, and there is a hemivertebra. They divided to the hemivertebra, segmented, hemisegmented, unsegmented, or successive. There are a lot of hemivertebra. And then hemivertebral body, and 2 segmentation failure, unilateral longitudinal bar. This is unilateral longitudinal bar. B, bilateral vertebral block. This is bilateral vertebral block. And 3, mixed failure. Hemivertebra and longitudinal contralateral bars. This is the hemivertebra and this is contralateral bar. This is hemivertebra, vertebral block and longitudinal bar. This is bar and this is the hemivertebra and block vertebra. This is mix. And intermittence, there is a hemivertebra, normal vertebra, hemivertebra, normal vertebra. And alternate, again, this is hemivertebra, but there are a lot of normal vertebra between the 2 hemivertebra. And then they look at the congenital scoliosis with rotational imbalance. This is the congenital scoliosis with rotational imbalance. 1, spinal tractions affects. This means there is a between F5 and sacrum, there is a fusion area. So because of that fusions, the spine make rotations. Bone bridge with congenital transverse sacral synostosis. 2, spinal pushing effect. F5 transverse process again, apotheosis, and again, when children is growing up, the spine has rotations. 3, mixed effect. There is a sacral agenesis here with pelvis malpositions. And this is different from other classifications. And we should know natural history because this congenital scoliosis is different from the adolescent idiopathic scoliosis because this treatment time is different. Sometimes we make direct surgery. Sometimes we make decision with growing systems, and other speakers will they will give detailed information about that. But in these presentations, we should know natural history, because this knowledge need for making decisions for treatments. Important progressive potential of the scoliotic curve and the progression rate depends on type of the anomaly. In lateral bar and hemivertebra, there are different progressions, and we should know patient's age, because this is affected the natural history, and the place of the curve is very important. This is different in main thoracic and thoracolumbar junctions. If there are more than one hemivertebra, successive or intercalary, the kyphosis will get severe. For example, curve progression is induced by an unequal accelerated growth on the side with a hemivertebra. And in the presence of longitudinal bar, progression is fast. And fully segmented hemivertebra, again, progression is fast. Segmented hemivertebra and contralateral bars, most progressive type. And the progression rate is about 10 degrees per year. And the curve progression rapidly in the first 5 years. Next, during the age between 15 and 14 years. This is a growing time of the spine. If the vertebra is butterfly vine, the spine is balanced in the frontal plane, but there is initially mild kyphosis present, and we should know in butterfly vertebra. And again, we should know fully segmented, hemisegmented, and segmented vertebra has different progresses. There is some examples. For example, adjacent successive 2 or 3 hemivertebra disposed unilaterally inducing short arc scoliosis. For example, unilateral 2 or 3 hemivertebra placed unilateral leading make long arc scoliosis. And there is a composite, sometimes hemivertebra, 2 symmetric hemivertebra in a 4 and 5 vertebral segment inducing an equilibrated spinal deformity, not requiring surgery. But uncompensated scoliosis, if the hemivertebra are disposed on a distance of more than 6 vertebrae, leading to double congenital scoliosis. And this is examples, natural history of the vertebra. This is successive intermediate vertebra with fully segmented hemivertebra, and the progression is high in this vertebra. And now we can talk with some clinics. For example, we can see here hemivertebra, and there is a disc space upper levels, and there is again this space inferior levels. And this treatment is simple, but we should know this is hemivertebra, and there is a complex anomaly, posterior arc, and there is a kyphosis. Sometimes these patients come to us with kyphosis. And this is again another case. There is a segmented hemivertebra, and this is 6 years old. Again, these patients come to us with kyphosis and sitting balance. And this is 6 years old. And this case, 9 years old. And when we look at here, we can see here bar and hemivertebra. And this patient has come to us for shoulder imbalance and body tilting at the right side. This is the clinic appointment to us. And this is another case. This case has here hemivertebra with fusions, the upper level. This is segmented, unsegmented hemivertebra. These patients come to us. This is 15 years old. Again, he come to us shoulder imbalance and body shape disorders. Only this is the effects. And this patient is 15 years old, She has diastometamia surgery, and she come to us with again shoulder imbalance and body imbalance and kyphosis. And when we look at these patients, 3D CT images, there's a lot of fusion block vertebra. 4 vertebra here, there's a block vertebra. At the same time, costa has a fusions. And here we can find hemivertebra. This hemivertebra has a fusion with block vertebra. This is thoracic block vertebra, and this is hemivertebra, partial segmented hemivertebra. This is our focus area, and this area is hemivertebra. This is fusion vertebra, and this is the kyphosis. This is post-operative images. Now this is case 6. This is 15 years old, and this patient has again diastometamelia and tattered cord. And this patient again has, this area is fusion block vertebra. This is normally this space, but there is a fusion in here, and there is a hemivertebra in here, wedge vertebra, sorry. And this wedge vertebra, again, there is a posterior fusion, this block vertebra. And there is again operation area. This is wedge vertebra area, and this is fusions vertebra area. And this is the case 7. These patients come to us again, shoulder imbalance, and there is differences between leg lengths. One of the legs is taller, the other one. And when we look at this patient, see the images, we can see here bar, there is a bar, and there is a hemivertebra, and there is a contralateral bar. This progression is very, very fast, and treatment is in early age and late time, like 15 years old. This is a difference. This is wedge area, and this is the bar. This is the contralateral bar. And we will continue. This is case 8. There is this patients come to us kyphosis, and when look at the CT images, this patient has meningomyelocell history, and there is an open failure of failure of segmentations and failure of formation, sorry, here, because there is no posterior elements between L1 and L5. There is an open area. Because of that, this patient is paraplegic, but when she is sitting, the kyphosis develop, and we look at the 3D images. Is there any other anomalies? For example, in here, hemivertebra, and this patient has kidney anomalies at the same time. So there is a kyphotic area again, and this is the vertebral area, wedge vertebral area. And this is again the same patients and post-operative images. This case is come to do us the difference clinic, because these patients come to us with open wound. This is the osteomyelitis, and she takes approximately 1 year antibiotics, but she don't heal from antibiotics, and there is a large open wound area, and there is osteomyelitis at the same time. Sometimes patients come to us like this, and sometimes we can see again in CT scan and 3D CT for CT, there is again failure of formations. There is no posterior element of vertebra at this area, and there is a here hemivertebra, but this occur because of the osteomyelitis, and this patient has again kyphosis. This is operations, and this is case 10. Again, this patient has myelomeningocele history and kyphosis. There is a very huge kyphosis. These patients come to us were sitting imbalance, which takes approximately 2 months ago. There is a hoop, and there is again formations failure. There is no posterior elements at kyphotic area. And this is the CT, 3D CT images. We check with 3D CT. We can find another anomalies here again. And this is postoperative. And this is the last case. This is the kyphosis, but this is congenital and at the same time neuromuscular scoliosis, because this patient has Ewing sarcoma at the same time. There is a hemivertebra here, and there is a cervicothoracic junctions kyphosis here, and hemivertebra and wedge vertebra here. And this is the postoperative. And thank you for listening to me. And
Hello?
His connection has been lost, I guess. Yeah,
It's back. It's back.
he's back.
Yes, now I hear again. It was away for a few, maybe 30 seconds or
Yeah.
what.
We can probably wait a few minutes.
sorry.
Yeah. Yeah.
Thank you. Sorry,
Okay.
Wi-Fi is go, and I join again. Sorry.
So that was quite an impressive presentation with all your cases, which you probably collect over the whole country, I assume. You know, this is quite, I think one of the most important message what you give is that there is no simple congenital malformation of the spine, or it's very rare. In fact, most of these malformations are combined with different pathologies at the spine, but also in other systems like the cardiac system or the urological system and so on. So it is this is a challenge, but this pathology, you know, and this severe deformity is what you have shown. I mean, probably the majority of the spine surgeons will never address this. This is beyond their scale, because I think if you want to do this kind of surgery, you have to do it on a regular basis. You cannot just do one case a year or whatever, you know. So I think it was really very impressive what you have demonstrated. Are there any questions from the participants? No questions? You have any comments to make, Dr. Aya? It seems that you are interrupted again.
Yes. I wanted to say only something. If we detect this deformity early, everything is simple for surgeon and at the patients too. It is very important to find this vertebral anomaly very early. This is my presentation's main sentence, I think. Detecting it early.
I will just, the next presentation, I will just start with this sentence. I prepared it exactly in this way, you know. You are absolutely right. So no other questions or comments from the audience? So then let me try to share my lecture. So where is my lecture? Share. So can you see this lecture?
Yes.
Yes, very, very nice.
Okay. So let me talk about this topic, which is a very specific topic in this whole context of this complex issue of congenital scoliosis. As it has been said just as last sentence, I start with exactly this sentence. I think the early detection and the treatment is very crucial for preventing severe spinal deformities, because the severity may change with the growth. So the growth is a fundamental issue in this whole development of these deformities. And of course, it depends, as we have seen, from the type of the hemivertebra and its location, and whether it's combined with other spinal malformations, and if so, whether it's symmetrical or asymmetrical malformation, and whether it's combined with kyphosis. This again is another issue. So how can I advance this? Let me see. So it is very important to do a proper preoperative evaluation to differentiate the different problems we have in this pathology. So the plane radiographs are still there, specifically to judge about the balance of the spine, and including the bending and traction pictures. For me, the traction is more important than the bending, because the bending has different is submitted to different problems like own muscle activities, whereas when you really do traction films, you can see how the spine can develop when you take the load away from the spine. And then it's, of course, this 3D reconstruction of the CT is very fundamental today, as we have seen. And I will show again for the preparation of the surgery and the execution of the surgery. And today there is a debate whether you don't need any more CT scans, because of course this is irradiation, and whether you can do that all with the MRI. And because you need an MRI to exclude intraspinal pathology like syringomyelia, tensor cord, hematomyelia, and so on. So the question is, do we need the CT? Can we not do everything with the MRI, which also delivers the information about the intraspinal issues? So we have to be very well prepared when we go into the surgery. And until now, for what we do is we use the CT scan. And what is the crucial issue in the anatomy is to understand that the AP view and the posterior view can be very different. So if you address an issue with surgery, you have to be clear what you're really addressing. It has been shown before by a colleague that, that the combination is sometimes very strange between the anterior perception of the malformation and the posterior perception of the malformation. And of course, you can use the CT scan to really plan the surgery. Like in architecture, you can measure the screw length, you can measure the screw size, and so on. So you can make a surgical plan with that. Here, just to emphasize that you have to be clear that the anterior appearance, what you see when you look from the front to the spine, and when you look from the back, and in the surgery, you go from the back for this specific problem, they may be different pictures. as you can see, for instance, in this part above, where you have, I try to get this rid. Oh, excuse me, now I have done a big mistake. Ooh, I wanted to make my picture better, but now I have done something wrong. I don't know what the hell I have done now. Let me do this. So I don't know why my screen. So yes. So as you can see here in this in the right upper corner, you have a posterior malformation, which is a complex one. It is a fusion between the transverse processes, but also partially from the ribs. And anteriorly, you have very nicely a hemivertebra, and you think it's a straightforward issue. So you have to be careful when you analyze this X-rays. And I don't know why I cannot advance this. What do I do wrong here? So, yeah. So the indications depends, of course, what the classification is, as we have seen. So the classical indication is the so-called single segmental hemivertebra, which usually is treated between 18 months and 4 years. We always say it should be done before the age of 5. And we have to be aware that this can be anywhere in the spine. It can be at several places at the same time, multiple, it can be combined. So, of course, the most simple one is one in the lumbar or in the thoracolumbar spine, as an example here. And you see that the preoperative planning and imaging is very important. So you see here a case of a 8-year-old girl, which has not been detected before. She came with this problem and with a certain imbalance. And she had on the X-ray, she had a hemivertebra, and here a little bit magnifica, a little bit more bigger. You can see it here. And you see the MRI, and in the MRI, you can already see that this malformation is a little bit more complex than just a simple hemivertebra, because it's combined with a kyphosis and with other malformations of the adjacent vertebra. So we have to figure out which one of these vertebrae is responsible for the deformity. So this is the CT reconstruction, where we try to identify the possible insertion points for the pedicle screws when we want to keep the whole surgery limited to this localized problem. And you can see here the deformity with the kyphosis of this vertebra, which is also malformed. And here you see an unsegmented hemivertebra. And so this is a combination between these two things. So I think the surgery here cannot just be localized to this and this. It has to be including at least 2 segments above and below. So here you can see the possible screw insertions. And at the end, that's what we did, which came out. It was a short fixation, relatively, including 2 mobile segments, but basically pretty well balancing the spine in the AP view, but also in the sagittal view, just by a localized procedure with a partial resection of the hemivertebra and some osteotomies in the back. Now, the resection of the hemivertebra, this is a technical standardized issue. I think you have to identify the pedicle which one you want to resect, and you have to isolate it by cutting down the transverse processes and partially the rib sometimes. And you may use some sort of like a ponte osteotomy of the lamina to free this vertebra, to isolate the pedicle. You can use, of course, the conventional kerisons, rongeurs, or microdrills. Some people today, they use ultrasonic scalpel. We don't use that. you have to, once you have the canal open, you have to identify the relationship between the nerve root and the dura to the pedicle you want to resect. And of course, you use all kind of tools to make the blood loss as minimal as possible. This can, if you go fast and you don't really look exactly, give attention to the vascularization, this can create pretty strong bleeding, and you can control the bleeding with different tools, of course, with bipolar cauterization when you have isolated the vessel, but you need some other tools like the neuropathies to identify exactly the bleeding points. And when the pedicle once is isolated and resected in the superficially, you can excavate the pedicle either, or you can cut it down. We sometimes use a shunt screw just to open the pedicle, and then we can go with a curette into the pedicle and already start to excavate the vertebra, the hemivertebra, because then the neurostructures are preserved. You are not in contact with the neurostructures, and once you have finished this process, you can take down the cortical wall of the pedicle systematically down to the vertebral body posterior wall, and you can go still you can use the posterior wall to protect the dural sac before you really finally open the whole segment, and you resect the end plates, or you freshen the end plates, and to place rods when you have done that. So the thing is, of course, that you may need in unstable situations, so-called unstable situation, you may need at least one rod to put already at the beginning, just to make sure that this segment is not moving around when you are decompressing it. So the realignment, then you do, of course, with today mostly you do that with rod and screws. You can use in very small children, you can use lateral mass screws from the cervical spine system when you don't have a pediatric spine system. You may use additional hooks or screws just to unload this, the major fixation when you do the correction. So you can distribute the force on different implants, and therefore you may prevent the loosening out of the screws before you even finish the surgery. It is clear today that most people use screws, but in fact, you could theoretically also, and we have also done that in situations where there were no implants available. You can do the whole resection, and then you can basically correct manually the patient and put the patient in a cast. You can use also sublaminar wirings or tapes and hooks, but usually with this technique, you cannot limit the whole surgery on one or two segments. You have to include more segments than just one or two. And once you have done the resection, you have removed the hemivertebra, then you have to put the rods. You can pre-bend the rods into the kyphosis, and then you can rotate the rod out of the kyphosis, and you can create a lordosis to correct also the kyphosis. You can use distraction on the convex side, on the concave side, and you can use compression on the convex side. So you can combine these different maneuvers, and you can even use the table. You can breach the table to basically try to correct specifically when it is kyphotic. You can correct the kyphosis by bending the table. Post-operatively, in most of the very small children, you give, at least we do a cast, just to prevent any secondary problem, because they're moving uncontrolled. Or you can, in the older children, you can use a brace, and usually this goes for 2 to 6 months, and then you can deliberate these children. There are complications, of course, and all the complications which exist in spine surgery. And most prominent, of course, during the surgery is the neurovascular complication, or the complication of the dura, of the dural sac. And of course, the postoperative complications are mostly infection, sequelae from blood loss, ileus, pancreatitis, pneumonia, and in a longer term, it's loss of fixation. It may be a pedicle fracture, implant failure, and so on, and a secondary malalignment or non-union. So I think when you look in the literature, you can see that the complication rate in series, and I have put some here, you can see that the complication rate is usually below 10%. The biggest complication rate, in fact, has the group of harms, but I assume they have a very complex pathology, and I think it's a little bit a mixed pathology, so it's very difficult to say whether they all talk about the same thing when they talk about complications. So you don't need a lot of rehabilitation in the children. You may use some physical therapy, but normally they gradually return to their activities. Children feel better than adults what they can do and what they cannot do in general. I think you need the pain management, which is again in children not a big issue. It's just immediately post-operative. You have to monitor for complications, and you have to do a radiological follow-up. Usually we do 3, 6, 12, and 24 months post-operatively. If the patient has no clinical reasons, we avoid X-rays in the meantime, just to see what is happening, because these kids, they get enough irradiation by their with spinal deformity, so you should avoid to do too many X-rays. Only when there is justified clinically you can do it, or you should do it, of course. If you talk about outcome, a positive outcome is when you improve the spinal alignment, when you reduce the progression of the scoliosis, and when you improve quality of life. And you have, of course, complications, as we mentioned before. And one of the major problems is certainly a residual or recurrent deformity, because you have addressed maybe the deformity or the malformation not completely, or you have overseen an radiation deformity. So this is usually the major issue. Here is an example of a patient where we did some years ago, maybe 3 or so years before we have seen her in this condition. We did a resection of the ribs. She had significant rib fusions on the concave side. We interrupted the bar, the posterior bar, and we did not address, in fact, this hemivertebra, what you can see on the convex side. We believed that the growth may finally balance that, because this is quite a big hemivertebra. But of course, we were wrong, and we had to finally, we realized that this ribs, they refused again, and posteriorly it was refusing again. So we had to do again an intervention where we resected the hemivertebra, as you can see here, and we had to choose a longer fixation. We had to do distraction compression depending on the site, and that's the postoperative result in this in this girl. She's doing pretty well, and she's quite happy about her body position she has. There are some other clinical examples which I may very quickly show. There is here, for instance, a so-called classical hemivertebra in a 10-year-old boy. And you can already see in the simple X-ray that there is also a significant kyphosis, a malformation also in the sagittal plane. And when you look at the CT reconstruction, you can see, depending where you cut, you can see different pathologies. And I think you have to identify which is the major pathology to create this deformity, to create a kyphosis and a scoliosis. And I think it probably, the procedure consists of partial resection posteriorly and the resection of the hemivertebra. So if you want to be sure that you are going to do the right thing, you have very early on in the surgical procedure, you have to identify the hemivertebra, which you believe is the cause of the scoliosis, and you have to mark it. So your incision or your preparation may depend on that. You may do a wrong preparation because from the back, the deformity looks different. The malformation may be a mixed one, so you have posterior elements which are included in this malformation. So to be sure that you will get to the hemivertebra, I think you have to mark it very early on, so you can go there where this problem lies. As you can see here, at the end, this patient could be treated with a bisegmental fixation with simple screws and a brace postoperatively, as you can see here, with a satisfying result. So there are also complex issues like this one. We have operated this girl with a so-called hemivertebra resection, which was obviously incomplete. You can see that she was 10 years old when we operated on her in 2017. And only 3 years later, she has 40 degrees, so she continued to progress with the curve. And in 2024, she had 52 degrees, so she had a significant also rib hump in the meantime. She was 17, and she was very unhappy with her body appearance, and she basically wanted to have another surgery, which is, I think, justified, and that's what we did. We had to take the metal down, and we had to do some posterior resection and realignment of the spine with this result of 16 degrees. So in conclusion, posterior hemivertebral resection is a critical surgical intervention for correcting congenital scoliosis caused by hemivertebra. So it's a very limited issue in this kind of deformity surgery. And it is very important that there is a very precise planning and early intervention and a comprehensive care of these patients. Unfortunately, many of these patients we see too late because they are referred from somewhere else where they have been followed for a longer time without doing a surgery or a treatment. This is just a paper. I think it's an interesting paper as a reference. There are many references. You know, you can go on Google Scholar and you will have XREM references. It's not anymore necessary to list that all here. But this is a paper which reviewed 23 patients with in a mean age of about 3.5 years. And they had a blood loss average of 210 milliliters. And they had a hospitalization time for 4 days only. And they had only 3 complications. And this has been done in a country where they don't have all the technology available like in the industrialized countries. They have done most of this surgery for the small children with lateral mass screws from the cervical spine, and they showed that the results are as good as the results you get with so-called pediatric spine systems. So thank you very much. This is what I have to say for this. Are any questions, any remarks here? Yes, I hear, but I don't hear anything. No questions, no remarks?
They write to the chat box.
Sorry?
In chat, Professor Ebe, questions.
There are questions here. So, presentation. Yeah, so where should we start? So let's start with the...
Jerusalem Banti, the first question. Jerusalem Banti.
Yes. So it's an amazing presentation. I think this relates to your presentation, or how young is the youngest patient you have operated? So I can only talk for myself. The youngest is 3 years, what we operated. But some people even operate these patients earlier, but I have not done that. So the youngest patient I operate is about 3 years old. But I think if you have the right equipment, you have the right anesthesia, you have the right support from all the infrastructure of the hospital, you can certainly go with younger patients. I don't know how you handle that. Is this question answered? So what is the next question? Next question is, what is your experience about these deformities are flexible or rigid? Which one is high rate, even has congenital bar? So in my experience, the most rigid ones are the ones which have posterior bars. I don't know whether you have the same experience. If you have just isolated hemivertebrates, you may still have some mobility, but as I said, and I think you said that too, many of the so-called simple hemivertebra are not simple hemivertebra. They are very often combined with other malformations. So the flexibility of the malformation, which is the source of the scoliosis, is usually limited. The flexibility above and below, that means in the compensatory curves, this may be completely intact. This may be, and that's the reason why I think you should do traction films, before you do the surgery. Is this question answered? Then there is another question. Is there a relationship between Chiari malformation and scoliosis? Does it have an effect on progression? I think, again, in my experience, a Chiari malformation, an isolated Chiari malformation, is very rare. It's very often combined with other malformations. And so it's very difficult to say whether the Chiari malformation is really the cause of the scoliosis. I think the cause of the scoliosis, if it has a scoliosis, is usually in malformation which are in combination with the Chiari malformation. Any other ideas about what do you think about this? Yeah.
Or I wanted to say one thing with rigid, flexible or rigid congenital bar. This is rigid because the bar make the rigid area and there is no flexion in this area, and we need to make resections at the same time to hemivertebra and to the bar at the same time. The other one is the relationship between Chiari malformation and scoliosis. Yes, there is an argument this issue because in Chiari malformation, patients get starting to scoliosis because of the sometimes intact cord like this, and there is a relations. Some others supports these things, but there is no high levels. I know.
Yes. Then we have another question: how often do you employ robots during the surgery of congenital scoliosis? So who is using robots? I'm not using robots. I'm probably too old for that. But I think robots, you can apply robots when you really know how surgery goes. I mean, if people start to use robots and they have never done really the surgery, I don't think this is very promising for the future,
Maybe navigation have to do us, but we use freehand techniques. But robot is too difficult to put because this pedicle is again anomaly. Vertebra has anomaly. There is no directions. Pedicles trajectory is different each levels, and find hemivertebra, it isn't easy. We take a lot of fluoroscopy sometimes. I think nobody use robot for this case.
No, I agree with that, and I'm, you know, maybe everybody's talking about artificial intelligence now, and maybe you can program all this much better in the future. But I don't know. I have my doubts about that. If you have a problem, a complication, you know, then the robot probably will not solve the complication immediately. So I think if somebody wants to go in this kind of surgery and do this surgery, I think you have to really deal with this problem, and you have to understand the anatomy. You have to do anatomical dissections, so you understand exactly where you can go in the canal, what you can resect, and so on. So I think we are still away from a reasonable use from robotics, and whether this will be the case or not one day, I don't really know. So then there is a question here. Thank you. What is your opinion on placing an autograft or any cage for? Yeah, I forgot to say that. You know, there are more people now, they think when they do the resection of the hemivertebra, they put something anteriorly between the vertebra above and below, like a cage or a graft or whatever. I never do that. I don't see why I should put a cage that costs money for nothing. If you do a proper freshening of the end plates, and you do and you correct the kyphosis by the posterior tension banding system, I don't think you need anything in the front. If you have a lot of bone left from your decompression, you can mill this bone and you can stuff it down if you want into the defect. But I think this is not the crucial element. The crucial element is to freshen the bone, so the surfaces which come in contact with each other, they can heal like a fracture, and you stabilize it in a stable way under compression, you know. I don't know, is any comment about that or other opinion? Please then tell it. What do I have here? Do you often use bracing same as idiopathic? No. So, you know, when you have a congenital scoliosis with a malformation of the vertebra, with a structural malformation, I think the brace is more or less useless. I think you should not do that, or there are reasons. There may be some medical reason because the patient has other problems, the patient has cardiac malformations or whatever. But if the patient is able to be operated, I think it's a waste of time to try with the brace. I think the brace, yes, post-operatively we use brace just to protect the surgery for a while, but not for patients who have a clear congenital scoliosis. I think this is not the area for a brace. You have the same opinion, or you have different opinion?
I do like to bring up, sorry, it's Mike Falloon. I do like to bring up that sometimes when you've had a short segment congenital fusion, bracing is very helpful with trying to control those compensatory curves and maybe shortening a later fusion as they get older and you've already addressed the problem.
So if I understand you right, you think that you can, in a congenital deformity, you can control the adjacent curves? I agree.
I'm saying if, you know, there's so many congenitals that have compensatory curves develop much later.
Yeah.
Then I do believe the bracing of those curves to try and get them a little older for shorter segment fusions in the future, not for the congenital, but rather for controlling their longer term correction.
Yeah, I think this is an option which has to be considered, but I think, you know, if you diagnose a congenital scoliosis on the basis of a malformation, as we discussed it, if you want to give for a long-term solution the patient a chance, and there are no other contraindication, I think probably the most straightforward way is to treat them surgically. But you get patients who have, you have been missed, they have not been operated, and they have compensatory curves. And I think for them, this makes sense. And then you may, then in the, in the adolescence, maybe when they're 15, 16, you do the final fixation. I agree with that. So what we have more?
Yes, it's finished now.
Sorry, I didn't.
It's finished. All questions finished now.
So we have answered all the questions. Okay, so we are probably already a little bit behind, but let's go. It's very interesting what we hear here. So I invite Muharrem Yashichi to, I'm probably saying the name in the wrong way. I'm sorry for that. But I know your face. I know who you are. And so you are going to talk about management of syndromic cases, please.
Can you hear me?
Yes.
My screen is seen well? Great.
Yes.
Okay. Thank you, Dr. Avi. And also, first of all, I'd like to thank organizer for having me at this fantastic webinar with a great faculty. I've been tasked about to speak to instrumented fusion in congenital spine deformities. Unfortunately, some of my slides will overlap in Dr. Avi's slides. Okay, just a second. Okay, we'll go back. Okay. As all we know, congenital spinal deformities are among the most challenging curves to correct because they're complex, they're progressive and rigid, and they pose difficulties during correction. It's not necessary to treat all congenital deformities, but if treatment is necessary, the method should be surgical. Conservative approach have no place in the treatment, but I fully agree with Dr. Falloon, and in some cases, some congenital deformity having a big compensatory curve. For time-buying strategy, we can use the brace or cast in a certain period of time in their growth. This is the two cases in my career, and both of them as a congenital anomaly. One on the left-hand side, I saw first when he was in the 5-year-old, looks all the spine is having the multiple congenital anomalies from top to bottom, like a pebble bone. But in the coronal and the sagittal plane is very well aligned. We didn't do anything at the end of the maturity, and the body the height was significantly short, but no deformity. That's why he definitely didn't need any surgery. The second patient in the right-hand side on my screen is the deformity is a typical hemivertebrae between L4 and 5. Incidentally diagnosed when she applied to emergency department because of the bladder stone, and then the spine is well aligned, no significant deformity, and the patient is happy. Just only thing maybe we can say is the congenital and spinal stenosis. Maybe she needs some decompression in the future. Surgery for surgical decompression, but not for the spine deformity. Historically, correction and fusion with instruments have been avoided for many years in the treatment for congenital deformities for 4 main reasons. Surgery is too risky for these patients because of accompanying interspinal pathologies. It is too difficult to perform because of bone malformation. It is too complicated to achieve satisfactory results because of curve rigidity, and it is considered impractical because of current implant options are insufficient. Because of all these factors, until the early 1980s, surgeons were either compelled to utilize in situ fusion or only mild correction using cast followed by fusion. Despite being safe, this strategy of halting the deformity before it becomes evident is far from ideal because of the high rates of pseudoarthrosis and deformity progression. John Hall of Boston Children's published the first series of instrumented fusion in the literature, and his results with Harrington instrumentation were marginally better than those of traditional approach. However, in the last 45 years, many things have changed. We can now better evaluate our patients preoperatively. Our surgical and anesthesiologic techniques and technological infrastructure have improved significantly. We now have a wide range of implant options at our disposal. And finally, we have an extraordinary guide such as neuromonitoring. Thanks to these developments, we can achieve much more significant correction with safer surgeries today and maintain the improvements we have achieved. As a result, many things that we couldn't imagine in the past have become today's routine or today's normal. Today, we can operate in the patients of all ages, from 2-year-old babies to elderly patients. We can perform major reconstructions from upper thoracic, even cervical vertebrae to lumbar and sacropelvic region. From simple cases similar to idiopathic scoliosis to complex cases accompanied with intraspinal pathologies. And finally, we can perform complex triplanar osteotomies in cases where simple posterior osteotomies are not sufficient alone. However, instrumented fusion still continues to be challenging for pediatric spinal surgeons. Our challenges can be grouped under the two main headings: instrumentation and correction-related ones. The smallness of the patient's bone dimensions and insufficient soft tissue coverage and malformation of anatomy make our instrumentation difficult. The rigidity of the curve and wrist and the sick spinal cord in a significant group of patients also limit the ability to correct. Placing a pedicle screw as a standard state-of-the-art techniques today can sometimes be very difficult due to the age of patients or congenital backgrounds. The presence of posterior bony defect may make hook use impossible. The discordance of congenital anomalies in the anterior and posterior columns of the vertebrae, as Dr. Aby has clearly shown that, especially if not recognized before, forces the surgeon to make mistakes. In rare cases, rare cases, the lack of connection between the posterior and anterior elements makes it impossible to get a strong fixation from the back. Pedicle screw is gold standard today, but dimension mismatching is the biggest challenge for pediatric spinal surgeons, in general, all deformities, but especially congenital ones. Years ago, in a study we conducted on healthy infants and juveniles, we showed that Inner diameter of L1 pedicle was around 2.5 millimeter, and discussed that it was not possible to place screws with sufficient purchase strength in these pedicles with standard methods. Needless to say, the problem is more striking for a thoracic region. Our group also showed that the pedicles can be dilated in immature pigs, and that screws with larger core and thread diameters can be used safely. Today, we can safely use pediatric spinal implants even in 2-year-old children or younger by dilating pedicle channel. Sorry about that. Pedicle channel using incremental screws or tabs. Cervical implants can be alternative for instrumentation of children with small body habitus, especially in the thoracic apex or thoracolumbar junction. In this case, for example, the option of splinting this biomechanically weak instrumentation with cast or temporary internal bracing until the time of fusion should be kept in mind. In cases where there is no pedicle or screw placement in some reason is not possible for some problems, using in-out-in technique or simply hook placements can be a life-saving for surgeon. Although it is technologically possible to produce shorter and thinner screws, certain size of screws, but certain size of the screw heads can cause problems for soft tissue coverage in small children, especially in the junctions and apex regions. In this case, using fixed head screws instead of polyaxial screws, or simply bypassing this area without implants in case requiring long instrumentation can be valid alternatives. This is the issue is already covered by Dr. Aby. In order to understand the spinal anatomy well, all congenital deformity cases should be evaluated with preoperative 3D CT. Discordance or mismatching between anterior and posterior elements is not uncommon. A careful preoperative analysis protects the surgeon from a major mistake that may be made during surgery. This is especially critical for hemivertebrectomy. Although the rare cases of pedicle absence involving multiple consecutive segments are encountered in some cases, this connection between the posterior and anterior elements, as you see here. These cases are not good candidates for pedicle screws and are not ideal examples for hook fixation as well. Rib fixation or anterior instrumentation options should be considered in preoperative planning. I don't know what's okay. As for challenges for related to corrections, Sorry about this. I don't understand what's going on. Okay. The prerequisite of achieving reasonable correction without causing early implant failure or neurologic deficits is to increase deformity flexibility. Halo gravity traction is a frequently used adjunct method for congenital deformities. Deformities can be reduced and their flexibility increase with gradual distraction covering weeks or months. The most common additional intervention for rigidity are posterior osteotomies, from the simplest to most complex ones. I apologize from everyone. Okay. By combining Schwab 2 osteotomies with rib osteotomies, concave rib osteotomies particularly, reasonable corrections can be achieved in most complex, long sweeping deformities. In acute angular deformities involving okay. In acute angular, sorry, I'm just closing my screen and checking it. Slides, presentations, options. Okay, just a second. Hopefully it works. Okay, this is the Schwab type 4 osteotomies. In acute angular deformities involving the short segments, the osteotomy should also include the anterior elements. In pure sagittal deformities, the Schwab 4 osteotomies may be sufficient, although it's very rarely. In three-dimensional deformities involving larger segments, removal of the vertebral body along with the adjacent discs or even multiple vertebrae may be indicated. The presence of concomitant spinal dystrophism is another clinical scenario that complicates our deformity surgery. I will not go on into detail about this topic, as it is the topic of the next talk. However, I'll conclude my talk briefly summarizing our approach for these patients for whom there is still no widespread consensus. For many years, we have been performing deformity surgery in patients with syrinx or tetrad cord or type 2 split cord malformation under the guidance of multimodal neuromonitoring by strictly avoiding vertebral column lengthening maneuvers without performing any neurosurgical intervention. But if type 1 split cord malformation is within our surgical field, we simultaneously remove the bones sequentially and continue with deformity surgery. If the spur is outside of our surgical field, we don't plan any neurosurgical intervention for these patients. Here are some examples. 2 separate patients with syrinx at the top, on the top, and low conus on the bottom were successfully treated with shortening osteotomies without touching a spinal cord. And the patient at the top with split cord malformation, local deformity, concerning the segments distal to the spur was corrected without intervening with spur, but in type split cord malformation type 2 case in the bottom, we absolutely don't perform spinal cord surgery. However, in the split cord malformation within our surgical field, like this patient, the spur was excised first by neurosurgeons. The dura was turned into the single tube, and deformity was corrected with the standard technique in the same session. As a take-home message, congenital spinal deformities can be safely and effectively treated with instrumented correction and fusion in January 2025. However, patients should be evaluated in detail before surgery. Surgery should be started with implant set prepared for all scenarios, including wire, cable, hook, rib hook, and pedicle screw and lateral mass screws. A meticulous surgical technique should be executed. Pre- and intraoperative additional interventions to increase flexibility, like osteotomies, either posterior column or anterior column or rib osteotomies to increase flexibility, should definitely be planned and implemented. And type and location of intraspinal pathologies should be analyzed in detail, and the most appropriate method should be selected, and surgical intervention should definitely be performed under the guidance of multimodal neuromonitoring. Thank you. Sorry for a technical problem. I apologize again.
Thank you very much for this perfect overview. Are there any questions from the audience? May I ask you, in cases where you have a tested cord combined with an deformity, do you do a release of the tested cord before you start to operate on the deformity, or you do that together, or you do not do that because you don't want to lengthen the spine? So how do you handle this?
Great questions. First of all, we have to differentiate. And tethered cord is the MRI diagnosis or clinical diagnosis. And in most of the cases, we can see the conus should be a little bit lower than the original place, and also we can see some tight phylum. But most of the patients doesn't have any clinical symptoms. In those cases, if we are planning to perform any shortening osteotomies, like hemivertebrectomy or vertebral column resection, we are not performing any the neurosurgical procedure either before or simultaneously with our deformity surgery. But I think the critical point is you have to have a good multimodal neuromonitoring system. But if the patient having the low conus or tight phylum and also documented progression of his or her neurologic symptoms, of course, this group of the patients should be considered differently. But simple answer for your question, our decision making is not based on the MRI picture, mainly for clinical symptomatology or clinical findings.
Thank you very much. I think this is also the way we handle that, but there's always the discussion, together with the neurosurgeons. They always tell us we have to release first the tested cord, and I think it is very important to see whether there is a clinical evidence for this problem. Okay, So is there a question? May I ask you? Thank you. This is functions that appears at the bar. Concomitants, thing. How do you open the fusion in this different segment with osteotomy in addition? Very complicated question. Probably you should read yourself. I don't really follow that. You know what?
One is so the whereas in the facet fusion, you see, appears unilateral but increase the curve angle, how the open fusion, different segments of osteotomy. Okay. Yeah, some congenital cases, you're right, and the facet joints at the back is already being fused. But to make complete osteotomy, I mean 360 degrees for hemivertebrectomy or vertebral column resection, you have to make in the 360 degrees osteotomies. You have to release the spinal column and all from back, front and the back. In those cases, of course, you have to cut the facet fusion, facet osteotomy. You have to make in the facet osteotomy. And in those cases, usually we use the burr, I mean the Midas, or if you don't have in your environment, also you can do the facet, the excision, it's easy, even you can perform with the Carson rongeur. This is not a difficult procedure, or the ultrasonic monoscalpel. Yes, the answer is yes. You have to release all the bone-bony connection from back and from the front. Dr. Avi, may I give some answer for the previous questions you already discussed before my talk? Regarding the cage use, I'm the cage lover. I use most of the cases in the cage, in the small cage, is not in the fancy and expandable cages, a simple harms cages. I mean, this is the 10-centimeter cages. It's good for maybe 10 patients. You can cut it and it's not too expensive. I use it for two reasons. One, a simple one is the practical one. Because of the serrated edges of the cage, gives some extra stability during the correction. It's not a huge stability, but it really gives some rotational and translational stability. But most important things, the simple hemivertebrae cases in small child, bone-on-bone, the contact would be perfect. I'm not arguing it. But in the older child, or the patient needs more resection, in those cases, if you compress the spinal column perfectly, you can create some spinal cord buckling. You can create some, if you shorten the spinal column too much, the spinal cord is going to be buckled and it can cause some neurologic problems. In those cases, to placing in the cage in the anteriorly to get in the balance correction. You can distract anterior a little bit and you can compress in the posterior a little bit, or distract in concavity and compress in the convexity. You can get in the better balance. This is my point of view. And the second thing is about the robot. I believe in the question is not directly the robot. Probably the question is related to the navigation. Yeah, the navigation is different. Okay, the robot is doing itself, but the navigation, it's the surgeon's helper. The navigation is not all cases, but in the revision cases or complex deformity cases in the small child, it's really useful. But in small child, also one of the drawback of the navigation, as the spine moves too much because of the body size and because of the, flexibility of the whole body, sometimes to interpret the navigation image is not easy. That's why the reliability of the navigation in small child, at least in my practice, it's some questionable. But if you have a navigation in your institution, it would be good in some complex cases if you have some difficulty to understand anatomy intraoperatively. Even if you study it perfectly before sometimes you can understand well. And finally, the bracing I already mentioned can be used as a time-buying strategy. It's not in a definitive treatment, but time-buying strategy for the patient. Those have some big compensatory curves. And if you can postpone the surgery in the certain years, you can easily perform the simple definitive procedure instead of growth-friendly technique in the many surgeries over the years. That's my answer to previous questions. Thank you.
Thank you. I think I can agree with your argumentation. I mean, it's absolutely valid. You know, the patients where I'm involved in congenital deformities are usually very poor people who cannot afford the thing, so we have to get funding to treat them and things like that. I mean, if you have no limitations by that, I can very well understand your argumentation for a cage. But on the other hand, you know, the buckling of the spinal cord is, yes, when you do it in the thoracic spine, this may be a problem, but in the thoracolumbar spine, this is not really a problem. You can play a little bit with the distraction compression. But I mean, there is nothing against your argumentation. I think it makes sense, you know. I just think, yeah, most of the cases we just don't have that available. I agree also with robotics. You know, robotics is not navigation. If you have a well-established team for navigation and the system is well-established in your operating theater, this is certainly helpful in very complex deformities where the anatomical landmarks are very difficult to identify and so on. So that's also something which depends a lot of the pathology, what you treat, and the availability of the technology, whether you have available these things and so on. I can very well understand your argumentations. Okay, so have you other questions, or shall we go to the next speaker? I would propose that we ask Michael Falloon now to give his presentation about combined or separate surgery for split cord malformation and scoliosis. Please.
Thank you. I was going to add one more thing to the end there, though it might be a little bit of a resource thing, but for congenital, a 3D model to have sterilized on the field during the case is just an excellent tool to be able to navigate your own self and to reorient yourself during the cases to distances and give yourself a great advantage, I think. But again, that's a resource that's difficult.
Yeah, I agree with you. In fact, we have in context of a research project, we do 3D reconstruction of deformities. We make models, absolutely one-to-one model, and you can sterilize them and you can have it on your table and you can basically have your model at your hand and what you have to do in your spine. I think this makes a lot of sense, you know, in the complex deformities. I agree. Okay.
Try and share my screen. Am I up and running there?
Yes.
Okay, thank you. First, let me thank Dr. Zalelli for the invitation. It's a little bit ironic, though, to be invited on a topic like this that I feel like some of the major knowledge is already in the room. And those people have to be acknowledged that I'll be presenting their research to them. You know who you are. You know, the one thing that this topic brought to my attention is that the vast knowledge that exists regarding the decisions to move forward with these treatments exists in very few centers and in the heads of very few people, who, as time goes on, we lose that knowledge. In the United States, with things like abortion, we don't see this very much anymore. We only see it a lot of times through immigration and such cases like that, religious things. So we're losing that knowledge. And so I saw this as maybe an opportunity to possibly kickstart some of those minds that are here, with putting together, the multivariable assessments for how to treat these cases. And I'll give an example of what I'm talking about. But so just quickly, to bring that example back, is that Winter and McMaster have some of that knowledge that exists, where we have these numbers that no one is really reproducing or showing on the grand stage with papers, because the volume is so low. But in terms
Sorry,
of
can you make image whole page? Thank you.
You can.
yeah, there we go.
Yeah,
Yeah.
perfect.
Okay. Sorry. So 30% of all congenital cases have intraspinal anomalies, and of those, 2/3 are split cord. These tend to be part of the most severe of the curves that exist, according to the initial epidemiology studies. And so, as I was saying, with regards to classification of early onset scoliosis, this paper set to look at what are those multivariables that affect our decision making in the treatment process of these patients. And split cord should fall into its own separate category for this decision making, in terms of trying to define what the treatment regimen should be. So breaking it down, whether or not or how you make your decision on single stage versus dual stage, the patient factors that are there, and then the surgical factors are there, in terms of what are you going to do. So some of these multivariates should be age, the hemodynamics of the patient, the bone morphology of the actual pathology itself, cord status, and curve magnitude, as well as risk of progression. I think some of these, and within these, are the factors that should be looked at. And then the surgical factors. Are you doing resections? How many? What are the osteotomies? What type? What is your fusion plan? Short? Is it long? What is the blood loss at the time? What is your OR time? And certain things and factors like having 2 attending surgeons have been shown to have an effect on things such as OR time. So this is a nice paper that looked at congenital scoliosis and operative treatments. And the patient factors that we have to look about are, what are the comorbidities that these patients have that affect our operative experience? And what's very notable about these patients is we know that they do have a great amount of cardiac and pulmonary anomalies that lead to and affect cardiopulmonary function. The study showed that every single one of the congenital cases showed a great risk with decreased FEV1s, decreased vital capacities, and overall cardiac function. I bring this paper out not as a self plug, but I think it answered one of the questions that was posed before. We were forced to kind of change the title of this, and I really was proud of this paper in terms of, we looked at all of the papers that were published, and there's 18 very good papers on MRIs preoperatively on patients undergoing AIS fusion procedures. So it included almost 5,000 patients, and the overall ratio is 8% of those who have been diagnosed as AIS when MRIs are done preoperatively demonstrate some kind of neuroaxial anomaly. And I feel like the fact that our title gets overlooked in the fact that we published this and it's been out there, and 33% of those end up having neurosurgical consultation and treatment. So other patient factors, and in terms of how is this going to affect, is the type itself, the bony anomaly, the type 1 classic, which has the bony ridging and the separation, versus the same dural sac and possible phylum. Another important factor that I think should be looked at in your decision making is the Lanky classification of looking at, again, very simple but very important, is what is the status of the spinal cord prior to the procedure itself? What is the morphology of it? And type 3 anomalies that demonstrate flattening or deformity of the cord itself on some kind of apical or concave pedicle or a bony surface with no CSF surrounding more than half of the cord are 28 times more likely to have an intraoperative event on monitoring during the case. And that's I think significant. That should be included in the classification. When switching, and in direct line with that, is what are the planned osteotomies? In my hands, typically I like to instrument my preoperative plan and get all smaller resections, etc., done first. Maybe not place a rod and do correction, but save the osteotomy for a time where I decide, can I proceed or not? Dr. Bawachi used to say that's the decision-making time, is when you're about to do the osteotomy. And what I can say is that it's nice to maybe go in, loosen up the spine, place your instruments, close everything up, put in a temporary rod, possibly put a patient into halogravity traction post-operatively, give them some time, and then come back and do a single-staged procedure where the second stage of the procedure is just the osteotomy, where you're coming in fresh, first thing in the morning, etc. We all know that PVCRs, etc., and in our small group, we take the procedure, we take the patient factors, and we need to multiply what the intrinsic rates of what we're doing are for the risk of neurologic issues. So VCRs themselves, we know, have a significant risk itself that needs to be multiplied by the patient risk. Back to the bony anatomy, is looking at the acuity of the curve. The deformity angular ratio has been shown in several papers to be one of the highest predictive values of having a neuromonitoring event intraoperatively. This goes back to where the spinal cord is. They're a little intrinsically related, but you can cause new neurologic deficits based on that ratio being higher or lower. And in this series, they demonstrated that the DAR, the angular ratio or the acuity, was more important than the procedures itself or the overall magnitudes. And signal losses occurred when those values were significantly high, greater than 27, you can see there. Also, back to surgical planning, there's an intrinsic risk. If you have a short segment, very long, if you have a short angular deformity and you have a long curve that's sweeping, I'm a big fan of internal distraction. Internal distraction has an intrinsic rate of significant intraoperative events. Lastly, just to throw this in there, we have to throw operative time into the equation and look at what our risk for secondary issues of complications like infections, etc., have to do with our planned procedure of staging versus not staging. That decision you get to hour number 7 and you realize how much more time you have left. I think intraoperatively you have to be ready to change your plan. Although in this paper here, which I think is a very nice one, looking at what the consensuses are, intraoperative time was not included in that, but this is what I would think we would be looking at by talking about the split cord plan. This is the deciding factor. Should you do a stage? Should you not do the stage? I think you make your plan preoperatively, but everything that we do in the OR is going to be driven by what the checklist is for if we have or don't have an intraoperative neurological monitoring event. And if there's anything that determines that more, it's going to be responsive to this system and neural monitoring. I know that speaking to my mentors, that this has been the game changer in allowing us to do this with significantly decreased complication rates. And it's almost like we overlook it to some extent now as we talk about this, but this is the driving factor, staging or not staging, and what those consensuses are. So again, ironically, I decided that the first outlook was written about doing safe non-stage procedures is only 2007, and it's by those in attendance. So they showed that it was safe, that it's well thought out, and if the plan goes to plan, then it's a viable option. I think it's also acknowledged too, though, that we need to look at 9.5 hours of surgery. Are there ways to shorten that? Should we stage it at that point? And are we creating new neurologic deficits, et cetera? That's intrinsic to the operation itself or not. But this is our starting point for even looking forward. And again, this was different than the classic approach at the time, which would be to do the neurosurgical event first and then go back and do the correction. And Dr. Yazigi just presented this, and I was actually hoping that maybe you would just keep going so I could learn something while you were giving your talk, because clearly the experience is there with that. And separating again type 1s versus type 2s, excellent demonstration that type 1s might have a more intrinsically and obviously resecting that a rate of increase in complication rate versus type 2s, which is going through with correction. This is a paper that then came out demonstrating corrective surgery without the resection at all. Sometimes when people report that they have no neurologic deficits with these type procedures, I have to maybe question it a little bit. But they had 214 patients, type 1 versus type 2, didn't perform any resections and didn't have any neurologic deficits. It's in JBJS, so it went through a very extensive review, I'm sure. But it's a lot of patients to not have a single neurologic deficit. This is a patient. This is a paper that sums everything up fairly well in terms. It's published in 21, but it brings together. It did an excellent review of the staging and non-staging literature from 2010 on. In and of itself, also they looked at their own series and pooled the majority of the data with the publications that they had, to obviously in increasing the magnitude of what they could say. They assessed 214 different articles within this, basically got down to 9, and obvious statements were that things like blood loss is increased with non-staged operative time, but more importantly, the complication rate was more significant in the literature with a single staged event. Now, again, that's encompassing all procedures that underwent a single stage. And again, the importance for us is to figure out the particulates and weed out why and who are those 28. But that's a significant difference in complication rates between the two. So obviously, it's not indicated in all cases. And I think some of the consensus that are coming out is that type 2s more recently, the literature focuses on a single stage. The type 1 is where many more of the complications lie and where the variables occur. And then I do add in there, things like halo gravity traction. When does that come into our planning process for staging this procedure or not? There's the option for the preoperative halo gravity traction, which increases things like pulmonary function, the ability to decrease intra-abdominal pressures and optimize patients with nutrition, loosen up the spine itself. Again, that's not applicable when we look at age. If you're talking about a 3-year-old, that may not be what we're looking at for a 9-year-old. So all in all, intraoperative neuromonitoring is really what drives us in our decision making for our plan. What do we plan on doing? Are we going to do 1-stage or 2-stage? What kind of resections are we going to do, et cetera? What am I going to do intraoperatively? But I'm obviously limited by the patient itself and their variables. So putting this together, the patient factors, the surgical factors, in order to drive more of a not classification, but at least a working decision-making tree. I think the experts need to break down the factors involved here for that decision-making tree. So thank you very much.
Thank you. Thank you very much, Dr. Falun. This is a very comprehensive summary of the available literature today and what has been collected over time by specialized centers. As I mentioned earlier this afternoon, all these issues are very specific for people who deal with this rare pathology of congenital scoliosis. I can tell you in Switzerland, we see maybe in the 5 university hospitals in Switzerland per year, congenital scoliosis to be operated on. Maybe these are maximum 10 cases a year. Whereas you go in areas like, I assume in Turkey, I work a lot in Pakistan, in Armenia, where you have in one consultation, you have 20 patients. So, the average guy in the so-called industrialized countries, they don't really see these patients. And you are absolutely right. I think there is so much knowledge from areas where this pathology is really present that it would be, in a way, times that they put this knowledge together, because I mean, even a resident or a fellow in a spine unit in our country, he probably sees that very rarely, So that we have to be aware of.
Yeah, there's a little bit of irony in it that, again, like in the United States, obviously we have great technology, et cetera, but not all of our surgeons have that knowledge. And some people end up leaving a country where, honestly, they've got strong opinions and strong knowledge and outcome and follow-ups, and they may end up getting somebody over here who has seen a couple,
Yes, you're absolutely right. Any questions, any comments from the participants? Yes. Do we have any questions here? No, I don't have. Any questions from the faculty? Comments? So I think if there is no questions, no other comments, I think we are already time-wise pretty much out of shape, but it doesn't matter. It's very interesting. I hope this is not the problem. So I may ask.
Sorry, I can ask both speakers, Michael and Muharrem, and also Yahya, but what is your attitude now? Do you make in stage surgery if there is a low conus or tethered cord, or in one surgery? What is your general policy?
Okay, I can start. And over the probably in the 20 years, we do the neurosurgical, if it's an indicated neurosurgical intervention, we do the same stages. I mean, the neurosurgical colleagues started their job first, and they finish. And as we are sure the neuromonitoring is okay, no problem, we can continue on our job. The reason for this, one is time consuming. Second, it's all the length marks, it's still clear. If you perform the neurosurgical procedure and deformity surgery in the two different setup, and the deformity at the time of the deformity surgery, it's even exposure, and placing the pedicle screw is more difficult than in the first stage. In our daily practice, we always do simultaneous sequential, and the neurosurgical colleagues start first, and then we check all the motor and sensory signals is okay, and we can go forward.
Thank you. Michael?
Yeah, again, the only from my perspective, again, so exactly as was just stated is the thought process. I do like the instrumentation prior to the type of osteotomy, and the resection is something, though, that I do like to save for last, because I'd like to achieve as much as possible in terms of the planned procedure in the first stage, and sometimes return to the osteotomy as its own kind of event. So in other words, it's very variable in terms of what we're talking, but in other words, go in, expose, instrument, and then see what time you have before performing a VCR, or you can always temporary rod. You can always return the patient back to the floor and then plan out the osteotomy time. You may even get more correction if you have them with a halo gravity traction on, you may have a better outcome with that. You can increase their nutrition. You can get them ready for the osteotomy and the big blood loss. You also don't want to be doing an osteotomy at 6 p.m.
Yeah, this is a great point. I just want the extra comment. Even we plan to stage the surgery, in those cases, we put in our pedicle screws in the proper places and then close the wounds to make everything is ready for second stage. I mean, the neurosurgical procedure is is always not creates any instability. Don't worry about to making the spine is unstable. But even you have a plan for staging surgery because of time issue, because of bleeding, because of vital signs, the instability. Even in those cases, the placement of the pedicle screw it would be great for second stage. It makes your job is easy. Definitely agree.
Great.
We are the
Thank
same.
you.
We are the same. In neurosurgical procedure, for example, in tethered cord or split cord malformation, we make small incision first. We release the tethered cord, and then we check the neuromonitor. After that, we start scoliosis operations. And in the stage operation is different. For example, in congenital scoliosis, for rigid angles, need to take long time for osteotomies. Professor Yazıcı said the same. We placement the pedicles and we close to the wounds. Then 4 days or 5 days later, we open again, we make osteotomy and we correct the deformity. But for neurological procedures, we make one stage.
I think we can pack up to this webinar. Max, would you like to tell something?
Oh, I would like to thank the speakers for their quite impressive talks. There is a lot of knowledge which has been shown to us. It's almost too much to get in one shot. as I said before, it's very important knowledge for people who deal with this kind of pathology. There are certainly spine surgeons who don't see this pathology, but if you see it, it's very helpful to have this knowledge which we just exposed during this webinar. So for me, I always learn. Also, I have done quite a few of these things, but it's great. Thank you very much for organizing that.
I also thank all the speakers for their valuable lectures and then very nice discussion. Goodbye, everybody.
Thank you.
Thank
Thank you. Bye-bye.
Thank you.
Thank you.
Goodbye.